It's the continuation of the previous video, starting from question number 11. Direct question, anti-PLA2R is a serum marker of which condition? Membranous nephropathy. Water, enough clue given during the quiz. CKD patient on dialysis through AV fistula. What is the diagnosis? This is the right limb, where you can see it is normal. Left limb is swollen up. The arteriovenous fistula, the radial artery, is connecting to the cephalic vein. The cephalic vein goes and forms subclavian. It connected by IJV, forms brachiocephalic internal jugular and goes to the superior vena cava and the right heart. Whenever there is a outflow tract obstruction, the artery is giving the blood at a higher speed and higher pressure, but the outflow tract is blocked. What will happen? The swelling will occur. So this is typical of central venous stenosis or outflow tract obstruction. Any of the outflow tract vein can be obstructed. Why this is? Because these kind of patient, probably they might be having history of hemodialysis catheter insertion in the neck. Already the venous pathway is somewhat damaged, which leads to the thrombus formation, and thereby they present with unilateral hypertrophy. This kind of massive limb is very. What is the treatment? You have to treat the outflow pathway, should be cleared of any stenosis, or you have to close the fistula, and it is very common. Those who have completed 2 months in Nephro at least might have seen 1 or 2 cases during your posting. Outflow vein obstruction after the AV fistula creation is common in those patients who had IJV insertion in the past, especially on the left side. Okay. Question number 13. Next best investigation. Even if ionized calcium is low or the total calcium is low, what is the next best investigation? IPTH and vitamin D. For MCQ purpose, clinically ask the history and try to find out as per the age. For MCQ, IPTH and vitamin D. Another spotter, many students wrote it as pneumonia, but look at the clue. 45-year-old male, severe shortness of breath, malnutrition, irregular dialysis. What is it? It is a counterpart of bat wing appearance in the chest X-ray. In the CT, particularly in this section, you can see these kind of diffuse infiltrates. At least in the axial section, you should be able to make out it is over the central predominant infiltrates. You will see only in pulmonary edema. If this kind of background history is not there, yes, of course, you can think of some other dairy, but if this background history is given, the diagnosis is none other than pulmonary edema only. The most difficult question during the quiz session, what is this spotter? Something is coming from below and entering the right heart. What is it? It is femoral permacath. Because femoral permacath is usually around 100 centimeter in patient whose other vascular axes are exhausted. For example, bilateral IJV veins are gone, patient is not affordable for transplant, fistulas are failed, or fistula could not be made because of poor vein, or if the patient is not affordable for PD, femoral permacath is the option. Permacath can be placed in femoral or translumbar route through inferior vena cava directly. It comes through the inferior vena cava and reaches the right heart. What is the problem in putting the small catheter is, if the catheter is small, because of the suction pressure during dialysis, the catheter will go and stick to the walls frequently. As you remember in the childhood when you were having the pen cap, if some kind of suction pressure is applied, the pen cap will stick to the walls like fingers. This repeated suctioning and damage to the wall causes vessel injury, thereby leading to the thrombosis. Whereas if we put the tip in the right atrium, the suction won't lead the catheter to stick to the walls because the blood flow is high in the right atrium. It itself will give adequate flow. So the suction pressure might not damage the wall. That is the reason behind keeping it in the right atrium. So this is the femoral permacath you are seeing in the X-ray. Simple question, hepatitis B vaccination. Whoever wrote 3 doses, 0, 1 and 6, or instead of that, if you wrote 0, 1, 0, 3 and 6, 3 doses if you wrote, we gave full mark. 2 ml, International unit wise, you have to write 20. International unit. Will write IM. These are other information you might require. Whereas in a renal disease patient, you might have to give 4 doses, double dose, 40 international unit. Whereas in an adult healthcare worker, 20 international unit, 3 doses. Look at the kidney here. Again, the purpose of this question is to make you understand. You have to observe the kidney images in the ultrasound report, not go by the wordings whatever is written. The kidneys are clearly visible. Urea creat is high. The clue is young adult. What is the answer? It is AKI. As you can clearly make out the kidney. If the kidneys are clearly visible, it is AKI. In diabetes, amyloidosis, HIV, kidney size can be normal, still patient can be CKD. At least for this particular, because many of the students wrote it as CKD. At least for this question, the discussion is if the kidney functions are deranged, the kidney is very much clear. Even if any other history is not given, then also the diagnosis is AKI only. This is different. Diabetes, amyloidosis, HIV, kidney size can be normal, still can be CKD. That is one peculiar point related to MCQ. Practically, even in diabetic patient, you might not find this much good kidney in CKD. Okay? The answer is AKI. Number 18, correct question, 3% NS 513 milliequivalent is there. Osmolarity is 1027 milliosmol. Whoever wrote it value somewhere nearby, we gave full marks. And there is a doubt among resident 513 milliequivalent per liter, and this is only 100 ml. So it contains only 51 milliequivalent. No, it won't work that way. For example, if patient sodium is 140 milliequivalent, suppose if you are giving 3% this 100 ml, are you giving 51 milliequivalent? Don't get confused by those things that we discuss separately in a video pertaining to this 3% NS only for that particular doubt. At least the answer for this question is 513 milliequivalent and 1027 milliosmol. You can see through the wrapper only in your ward during the rounds. Another direct question, viral occlusion is seen in SLE. It is more common in class 4. Multiple times has been asked in the past, in 2018, 19 times. Even current NEET SS, more likely you are going to encounter that question. Another spotter, what is this? It is serum protein electrophoresis showing M band in the gamma region. M band. Normally, this goes like this only, similar to this kind of peaks only. It won't give this much big peak. That means some kind of immunoglobulin is way too high, which is typical of monoclonal gammopathy, which extreme of which is multiple myeloma. So the answer is SPEP, serum protein electrophoresis is the investigation, which is showing M band. Whoever wrote monoclonal gammopathy, whoever wrote multiple myeloma, we give full mark. CAG classification is used in cause, albuminuria, G. G is GFR, is used in CKD. And this is what the colorful table you will see in Harrison. Green, orange, and red. This side GFR will be given, this side albuminuria given. This is what CAG is. Very important one. Whenever anti-PLA2 are positive, the guidelines changed. Membranous nephropathy, you might not do biopsy. No need to do biopsy. You can treat the patient as primary membranous nephropathy. And this value will be available in ELISA report. In immunofluorescence report, you might not get the value. If the value is there, the normal value is less than 10, you can follow up the treatment with this value only. So in this patient, the diagnosis is membranous nephropathy, no need for biopsy. Urine osmolality didn't change after administering desmopressin. What is the diagnosis? Just nephrogenic diabetes insipidus. Because in nephrogenic diabetes insipidus, the desmopressin is not acting or vasopressin is not acting. That is why there is no response after giving desmopressin. Whereas in central diabetes insipidus, where pituitary is not producing the vasopressin, you give desmopressin, there will be a change. Simple question, many students did it wrong. The answer is nephrogenic diabetes. Yes. Minimal change disease, what is the important investigation is electron microscopy. Without electron microscopy, you can't make the diagnosis. There won't be any finding in light microscopy. There won't be any finding in immunofluorescence microscopy. Only in electron microscopy, you will get food process effacement. That is why it is also called as nil disease or podocytopathy. Podocytopathy is the pathology of the podocyte, broader terminology. Whenever we send a histopathological report, this light microscopy and immunofluorescence, usually they will do. Only if we request for electron microscopy or if the patient is bit not affordable, many times we might stop with these two. Electron microscopy only will diagnose this food process effacement. That is for this MCQ. This is the answer. In clinical scenario where patient is not affordable for electron microscopy because it itself might be around 7,000 to 8,000 for reporting, and many institute might not be having this microscope. Only these two will be there. How to diagnose this MCD? Suppose if the age is common in the FCD age group, if LM and IF are normal, we usually make the diagnosis. Minimal change. This is that is for this question. The answer is electron microscopy. Another good clinical question. 70-year-old back pain, creatinine 2. A final MD resident should able to make the diagnosis here only, which is a UG mnemonic. High calcium, renal dysfunction, anemia, and bone pain. This is for UG. Here everything is there. Anemia, calcium is bit on the higher side. Patient is ultrasensorium. So what could be the diagnosis? Multiple myeloma, or whoever wrote monoclonal gammopathy, or whoever wrote plasma cell dyscrasia, we give full mark. Next best investigation is bone marrow biopsy, which will tell the plasma cell percentage, which will guide the treatment. Treatment include bortezomib, dexamethasone. These are the stuff you have to start. Some students who ever thought in lights of multiple myeloma, and even if they wrote protein electrophoresis, something related to it, like Benz Jones protein, we gave a mark. Okay? But as a medicine final year, you should be aware of the DD, back pain, old age, creatinine high, anemia. You should not miss the diagnosis. Two, false positive situation. What is false positive? False positive means patient report came as urine is positive. Okay, protein. The urine protein is positive. Patient is not excreting protein. That is what false positive is. Where you will get whenever there is a concentrated urine, whenever the pH are extremely little bit on the higher side, or in some situation where patient is on particular drug. Let us take a penicillin. UTI, very very common situation where it can be falsely positive, or lab error. These are all the false positive situation. CKD, diabetes, hypertension are the actual positive situation. Why this question was kept? When the word rounds, many a times as soon as you see proteinuria, don't jump into diabetic or any kind of renal dysfunction. These kind of possible false positive DD should be, you should be aware, because once these conditions are treated, it might change to negative. Okay, those whoever wrote at least any one of these two, we give concentrated urine, alkaline urine, or high pH, drugs, UTI, or lab error. Another simple question: salty wave hyperkalemia. The mnemonic is tips: salty wave, interval prolongation, P wave disappearance, sine wave pattern. Levels are 6, 7, 8, and 9 milliequivalent. And one more info: when to set salty wave: more than 10 small boxes in the chest lead, more than 5 small boxes in the limb lead, or more than 2/3 of the R waves. These are some criteria which is available to say as salty wave. This here, no need for any criteria. You look at the image, you are able to see salty waves. It's looking like the T wave is covering most of the ECGs. These are typical of hyperkalemia. What is the treatment? Acute treatment and the chronic. Acutely, you have to stabilize the heart by calcium gluconate, insulin with neutralization, sorry, glucose with insulin neutralization. Beta agonist you can give, diuretic, dialysis, the potassium binder like K-bind sachet. These are long-term management. Whoever wrote any of these, we gave full mark. Cancer index use. Another simple one. MCV by RBC. Less than 13 is thalassemia. More than 13 is iron deficiency. Most of the students got it correct. Enough clue was given. Uric acid is disproportionately high compared to urea and creat. Old age, cough, weight loss, malnutrition. What could be the etiology? Malignancy. Any malignancy can cause this kind of disproportionately high. Some students wrote tumor lysis syndrome. At least you got near to malignancy more than enough, because clinically you might get this kind of value where uric acid might be disproportionately high. What is proportionately high? For example, urea is 100, creat is 2, uric acid can be in the range of 8, 9. Or if urea is, let us take an example as 540, creatinine is 20, yes, that time it can be proportionately uric acid 16 can be high. But here the urea is on somewhat lower range, whereas extremely high. So this is very common in malignancy. How many stages are there in lupus nephritis? Direct 6 stages are there. So this completes question number 11 to 30. The next video we'll see further questions.